first question is, what are the challenges we are facing to create a truly integrated care world?
Can I talk about my mum?
Yeah, talk about your mum first. 110.
She's 92, 93 next month. Hands up if you're looking after an elderly relative in some way. Yeah, well, there's always some. Entirely independent until 85, and then memory starting to go. In the middle of COVID, she began to be really quite confused, paranoid about what the neighbours were up to, etc. And we couldn't visit and all the rest of it. And in the end, because you couldn't put anybody into a care home at that point, we had to bring her to live in our house, and she lived with us for a year. She retained enough insight that after a year, and when she started to need help with continence, she didn't want me to do it because I'm her son. So she had herself moved into residential care with the Little Sisters of the Poor in Newcastle, who run a care home. Because her dementia deteriorated to the point where she became dangerous, aggressive and violent, which is not like my mum worked at Marks and Spencer's for 50 years. She wasn't a hooligan of any description. But one evening at the Little Sisters of the Poor, she put a pillow over the face of a lady who'd been annoying her during the day, and then she has to have a psychiatric assessment. She needs a social worker. She needs to be moved to a more secure old people's environment where she has to be nursed one-to-one. And now she has what I call, and I touched on it earlier today, a constellation of care around her. She's got a regular old age psychiatrist, she's got a forensic psychiatrist, we've got physios, we've got orthopods, or we've got skin cancer as well, so we've got dermatology clinic visits. We've got the GP who looks after the care home. The Little Sisters of the Poor still visit in her pastoral capacity. She has an advocate. There's the family. We're involved as well. And there's continuing health care, which is a paper process that you have to go through to try and not lose every penny that you saved her whole life. So it doesn't go on care, but that's all gone. And then you have to have meetings. You have to get multidisciplinary meetings in the diary where all of these people, and they're all lovely people in the constellation of care. They're all stars, social workers, independent advocates, and all the rest of it. And you end up with this constellation of stars of care. They come from about probably 5 different organizations. And in order to effect a multidisciplinary meeting, as the relative, you have to integrate that care. And the constellation of care, they don't even know that each other exist. So to organise the first proper multidisciplinary meeting about my mother post the incident took over a year. And we only got half of the representatives there that you would like. I've put in EPRs during my time at the national programme right across the country. I've put in a shared care record across the northeast in which all my mother's information is available. I thought I'd integrated care, but what my mother got was completely disintegrated care. And that's the way it still is, I'm afraid, in terms of it. None of it really talks to each other, even though I think the northeast have actually done quite well. Even my beloved Great North Care Record is a bin bag full of PDFs. You know, I've got to go looking for the relative information. Nothing's pushed to anybody else. So my mother will go for an appointment at the RVI when she's due for an appointment with the physio department. And you get tremendous amount of waste and duplication.
Actually, it's a lot of the time it's people like Joe that are looking after their family that are the ones that actually hold all the information, and they will be the ones that go, oh, actually, no, there is an appointment over there that you need to be aware. Oh, so we can't do it then. It's just when you haven't got that unpaid resource, that family that kind of stand by the patient that can't do it for themselves. And that is one of the highest costs in healthcare, is having to navigate that person through health and social care at the same time. The two systems, well, never the twain shall meet. And it is the care records, the share care records, that their ultimate goal was to bring that information together. And I think, like I said before, over varying parts of the country, and there might be the two that have said yes to integrated care, some have really got it. Some have got onto the shared care experience, the shared record experience, made sure that it's implemented in the right way, and actually got the people that really matter to be able to look at it. But those people that really matter will only have a read version of it. So they have to have that patient present or be flagged to them in some way, because as we all know, that's not in the specification for the current shared care record. It's read only. So how are we going to then bring together integrated care at a point where these people are flagged to your services, to your mental health services, to your CPNs, to your community nursing teams, to the GP, to the hospital acutes when they go in, that this is all going on in the background? How do we know that that's going to happen? Now, I know that it's on the roadmap for a few of these shared care records to work through, but it's nowhere near coming to that point where it can happen, because the systems themselves don't allow that notification to push through, or whatever it is that needs to happen. And these are massive inefficiencies. And we're not talking small scale. There's a couple that happen here and there. If I was to look at just my own surgery, the amount of people that we have booked into healthcare assistant appointments who are just coming in for their health checks, for nursing long-term condition checks, or for GPs, ECPs, if they've gone into hospital, we don't even know about that until we receive the letter at discharge. So we can't cancel any appointments because we don't know that they're not there, unless good old Joe rings up and goes, oh, you know what, while I was accompanying my mum into hospital, I realised that I've got 3 appointments with some of the guys and one of the physios, and I've managed to get round to all of them, but I didn't know the phone number of the physio because it's from a different service that's not your GP. Would you mind doing that and calling? So you can see already there's several different people that are involved in actually just shutting down and allowing that appointment to be used by somebody else. Multiply that by however many million people we've got in the country that haven't got that Joe or somebody else to look after them, and you've got a serious amount of inefficiency that's plaguing acute, general practice, and everywhere that we're. I mean, even when patients die, there isn't that push through to say, right, you've got to turn off. There is a GP practice, but then all those associated areas aren't going to find out until the GP practice or whatever send out those things. So it's really, really necessary. Are we there yet? I don't think we are. Not with the shared care records as they are. The interop's all there, but what we haven't got is we haven't got a working system that enables clinicians and patients to really feel that everyone's sitting around them and knows what's going on with their care.
Well, look, I'm not sure how much more I can add to that, but I think there's a couple of things just worth noticing. One is that, the concept of integrated care isn't a static notion. It's dynamic, it's fluid, it's always continuously moving. And I think what's driving that in particular, and I touched upon this earlier, if I look at the practice of primary care in particular, that is considerably changing. As mentioned, 20 to 40% of my patients now being more in social and mental health related rather than pure what you would see as general practice. But even Amanda Pritchard, on her way out in her exit interview, highlighted that she believes that the NHS is contributing only 10 to 20% to people's actual health. The rest of it is taken up by the wider determinants of health around housing, employment, but also things around diet, exercise, and alcohol. So if you factor that in, it makes you really think what the purpose of the NHS is today, as it was previously what it was set up to do. So the point here being is that so much of what we're doing across the National Health Service today isn't at least focused on an acute setting or a particular building. It's actually all the things around it that makes up what we talk about people's health and society. So if you factor that in, undoubtedly we're going to have to do more integrated care. And it was interesting to see what colleagues talked about, the workarounds that we are currently seeing with things like email, phone calls, letter, SMS, WhatsApp. These are the workarounds people are making and happening that are actually providing integrated care. So the point being is that it will continuously evolving, we will continuously trying to define it, but it's more about how do we create processes in place that allow us to solve the needs of the day which is how do we build that for our patients, but also how we work more conducively together as clinicians and non-clinicians.
I think it's interesting that we've got shared care records, and there's been a lot of good work done in pulling data together to try and integrate the care, but somewhere along the way, we've forgotten about the people and the clinicians that are trying to work with that data. And people will say, but, you know, their admission, the details, it's all the episodes in the shared care record. But clinicians don't have time to keep going in and looking to see if something has changed. We need to be proactive around telling people that something has changed, and they need to do whatever they need to do with that piece of information, whether it's cancel an appointment or whatever. If ever there was any evidence of how big the problem is, we looked on our systems, and across our EO database in the last 12 months alone, we have got over 3 million DNAs for community nurse appointments. 3 million. So that's a huge amount of cost and time and frustration for community nurses. Because I do understand from the process when they're visiting that if somebody's not there, it's not a case of, right, I'll just go on to the next appointment like the DPD driver. They have to spend time finding out what's happened to them, and that can be a 2-hour process, which has a knock-on effect to the rest of their day as well. So that's really, really interesting listening to your stories there.
Can I give my favourite example?
Yeah.
There's a joiner employed by Newcastle City Council, and he works for the estates department of the council, normally maintaining council houses and doing things around the office and so on. But he's taken up pretty much full time because Ethel gets admitted to hospital and nobody knows. The milk bottles pile up one at a time. By the time it gets to 5 pints of milk, the neighbours notice, and they've got nothing they can do but phone the police. The police come, and because they can't get an answer, they kick the door in. And the joiner is employed to mend all the council house doors that have been kicked in because the milk bottles have piled up on the doorstep. And there's no other way of knowing that Ethel's actually okay, but in hospital. About £900 a door, since you asked.
Next question. So, in your experience, how easy is it to communicate and collaborate with NHS organisations and other organisations with the ICP? So let's start with Harpreet on that one.
Well, look, it's certainly become easier, right? I think there's been a flurry of new kit that we're all playing with. You know, if I can name a few, like, you know, we use text messaging services like AccuRx. You know, we've got portals that we use, emails I mentioned, phone calls. So all of those are becoming certainly easier to communicate. I think the biggest challenge we have is identifying who is it that we need to contact and who is on the other side. In my local mental health, we've had a primary care mental health set up recently, primary care mental health team, sorry. But in a space of like 12 months, there's been 4 consultants that have gone through that, right? So the challenge we've had is that when I've set up processes for my primary care mental health colleague to join us on a monthly basis for our clinical meeting, there's always been a different person, or hasn't been a person turning up. Now, again, from my perspective, acting as a quarterback for my patients, you know, I'm trying to set this process up, but the services around us are always chopping and changing. So it's about how do we provide a bit of consistency. So, and I think, again, I know everyone's in a different position, everyone's got different ways of working, there's issues with governance, etc. But I think it's often about who do we reach out to, or who is the right person, rather than the mode of communication. Because I certainly think that's got better, and I think it will only get better.
Well, I'm going to go back to what I said before around the digital oversight that the ICS has. So there's been a lot in the news around advice and guidance recently. There are platforms out there, Consultant Connect are the ones that will help GPs get in touch with acute hospitals. I'm not sure if it's rolled out into mental health sphere, but it's certainly in acute trusts. We've got ERS that you can ping messages to and fro, but there becomes a point where, well, actually, these can't stand alone. There has to be some kind of acknowledgement that this is time. It's time for clinicians. It's not something that's just added to the end of their, okay, I've done my full ward round, I've done a clinic, I've got 30 advice and guidances to get through now. And those can be massive cases that they're having a look at, but with a tiny bit of data to be able to do, like, literally just a question, a little bit of GP Connect data that they might have a partial story, but they won't have the documents that accompany that because it was somewhere in another trust that saw them before they came here. And actually the GP's writing for advice because they don't know what to do next and who to refer to, who to talk to next about this complex multi-morbid patient. And they know if they do that referral, it's going to be at least a year until they're seen. So we need to get something in place now. So those are the kinds of things where, and we're talking about acute, physical care. We haven't even gone on to mental health, and we haven't even touched social prescribing, which if you look at the bigger picture, if we get the other two systems right as well, you're then starting to see the efficiencies build up and up and up for that NHS social care spectrum. The other thing I really want to mention around integration of care is, I said it before, I'll say it again, patient safety. So those looked after children, we had a great conversation last night on the table around Hampshire and what they're doing around looked after children, but it's a completely bespoke local configuration that understands the national systems, how they can work with the child information system, how that then works with vaccinations, how they can keep an eye on patients going to and from CAMS systems, in and out, and they've got it licked. They've got a brilliant, I've actually taken down some emails and we're going to get some shared learning across the borders, but that's happening in one place. We're all doing that in individual places, and all of our safeguarding teams are tearing their hair out, thinking we've lost children, county lines, we've got issues going on all the time. This is where integrated care really works. If you're looking for use cases, look at the most vulnerable people in society. We've talked about the elderly. Let's talk about the children. They're going to be the ones that form society in the next few years. Let's get it right for children.
I think two comments as well on the children's side of things, because I think you're right. If we can't get passionate about those vulnerable people in society, we shouldn't be in the room anyway. You have to start linking children to other people in the household then as well. Yeah. So CPIS might show you that that's a child registered under CPIS, but what happens if somebody else in the household turns up in A&E because there's been a domestic violence case in the house? That's not necessarily going to tell that A&E consultant that actually we now have a vulnerable child at home with another parent that's just been violent, suspiciously violent to the other parent. So we have a real situation there that needs addressing immediately. And we go back to the Climby cases and the Baby P cases, and we still have a lot of those problems now that social care is not notified. We push data to places, but nobody's actually telling them there's been an incident, you need to do something with it. So, and I still think we're sitting on the same problems we were sitting on 15, 20 years ago. The Climby case was now, wasn't it?
Failure to communicate in every report.
Right.
Yeah.
There's been a dozen or more.
And at the end of the day, who's blamed? Well, it's that social worker, isn't it? It's that clinician that didn't see, but they're only working on what they've got.
Yeah.
And I think as a society and as us in public sector, we've got to start helping the social workers and the clinicians, because nobody wants to do those jobs anymore. We're going to find that we're going to have an absolute dearth of social care in the future. And why? Because these people aren't given the right protections that they need to be. We've got systems that can do it. The technology's there. Why can't we get on and do it? Why can't we integrate care properly?
I still think there's a significant amount of telephone tag from the survey question there. 50% of people are talking on the phone when they're trying to coordinate things. And I know I'm not easy to reach as a consultant psychiatrist. I'm usually with a patient if I'm doing my job properly, which means my phone's turned off and you can't get me. Equally, I can't get through to the GPs because, well, I can't even find out what number I am in the queue sometimes when I'm phoning a GP practice. I think it's probably the same when you ring us. But there's a significant amount of telephone tag plays when you're trying to talk to somebody.
I think email and SMS is an interesting one, email especially, because it's unaudited really. How do you know when somebody's going to read it? In the next hour, tomorrow, next week, next month? I think that's a real risk with email. Yeah. If you're sending important information and notifications.
I put at the bottom of every one of my emails, on my email signature, it says, do not write something about a patient on Rio and expect me to see it. Call me or call my secretary.
Yeah. we'll start with you on this one, Rowan. Why are you excited around working with Access around integrated care? How did we tease you into this role?
Well, exactly. Well, I came thinking I wanted to get my practice manager, not to keep going through lots of different systems. So I was really interested in the back end of what Access could offer, looking at their HR, etc. And then when I met Steve, he goes, "Oh, have a look at this, because I think you might be interested in this." And he knows, Joe, you're kind of clinical advisor for the North Care Record. I am for the LLR Care Record as well. And we are linked in the way that we understand it's a great resource. The interoperability's there, the data's there, but what we need is something to sit above it to actually start to do that in-out, so we can start to write in it and see what we need to see, given that we're in the role that we're playing at the moment, and we can ask questions of that data, and it will source the data correctly and give me something that I can rely on. We talked about 3 a.m. in the morning for the admitting doctor, but also I've got 7 minutes to make a decision on this person. I know that there's something not quite right going on, but I haven't got the right data because Ethel can't tell me, or the child that's in front of me, I can see that there's a very suspicious something or other going on with the parent, and I know there's more information that I'm not seeing that probably somebody else has written in there. How am I going to get there? So the reason now that I'm fully, I've been taken in by Access is because they've got the capacity to be able to do this. And that to me is the most exciting bit, that I think that if anyone's getting there, and we're talking a lot about the single patient record before, what my main worry is that those in the government will just plough on and try and do something that will kind of force everyone into doing something that might not work that well, but it's been funded and resourced from the top, so we will have to go along with it. Well, actually, we've got all of these shared care records. We've got a wonderful that interoperability has been done over the last 6 years, working with all the systems that we've currently got, all those legacy systems in hospitals, in general practice, finally, GP Connect, we had to force it, but it was there, and then in mental health, etc. So all of that work's been done. The data's there. What we need is something that sits over the top of it for clinicians and social care, dependent on who they are, to be able to actually access that data, the data that they need to see, all done by the RA, whatever they're registered as, and the right information is shown to them. So that's what really excites me, and I think that's what we're going to want to talk about, isn't it?
Yeah, Harpreet.
I joined because Rowan joined.
Fair enough.
No, I think a few reasons really. One, Access has been one of those organisations that over a significant period of time has built such a great footprint and scale that I think it's got such amazing potential to really deliver on what we are here talking about on the integrated care agenda, but also how we do more in community, mental and primary and social care. I see it everywhere, even more now that I'm part of the advisory board, but I just think there's a real opportunity that over the last so many years, everyone's been focused so much on the acute sector that actually this time is now ours, and I think it's a real moment of grabbing that by two horns and really going for it. And more importantly, how do we actually develop a global British champion that has really demonstrated that actually you can go and solve a problem like this that no one else around the world has. So those kind of things, as well as the final point being the data that Access really sits on, which we've talked about, I think puts it in a really exciting place to do some work together.
And Joe, you were the first one we duped into joining the show.
Well, you had me at hello, Steve,
Yeah.
to be honest. I've been a Rio user for 15 years. There was clearly an opportunity to improve it. I felt partly responsible for it being in half the country from my time during the national programme. But the Access Group are a British company. They pay their taxes in Britain. They sell software at a price that isn't silly. The ethics of the company were an important thing for me, in that I felt that it was the right ethical approach. They didn't want to take anybody's eyes out, nor take over the world, just join it up. And that fits with the philosophy, which I think is the right philosophy for building electronic patient record systems. Modular, cultivational approach, lots of partnerships. You can't try and take over the whole world. And frankly, nobody can boil the whole blooming digital health IT ocean. So you've got to have the right approach, and I think that the access
I think
group
what was
do.
exciting for me when you joined in particular, Joe, was the fact that you'd put in the Great North Care Record, something everybody there was really proud about. Everybody thinks it's the best in the country in the northeast. Everybody thinks Newcastle's the best in the country.
Of course.
There you go.
Of course.
But actually that recognition that actually it's still leaving a gap in
it
what
was
we need to
8
fix.
years ago, Great North Care Record. And yes, it's done great things, and yes, it's used 1 million times a month. Are we there yet? No. But that's the joy of digital health, to be honest. You're never really there. And there's always another level of improvement. And, you know, Care Records 2.0, if you're looking for something to call it, would be what I'm sort of calling it. But I think the Access Group has the best opportunity to deliver because of its, social care footprint and a healthcare footprint to actually deliver to neighbourhoods, whatever the neighbourhoods are going to be. And I don't know the answer to that, but.
Thanks, guys. I have to say, it's a pleasure having you all on board and the insights you're giving us. Every meeting we have, I find fascinating learning opportunity for us. So, welcome on board.
Thank you.